Welcome to the Pennsylvania Medical Home Initiative webinar titled Oral Health, Why in My Office, provided through a collaboration between the Medical Home Initiative in Pennsylvania, which is a program in the PA chapter of the American Academy of Pediatrics and funded by the Pennsylvania Department of Health. This webinar aims to obtain a better understanding of the etiology and presentation of early childhood caries. You will also have the ability to describe the impact of oral health across the lifespan and also gain a better understanding of the importance of fluoride, both topical and systemic. My name is Dr. Renee Turchi, and I am a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative and an avid Eagles fan. This webinar is recorded. The recording will be available on both the Pennsylvania Medical Home Initiative website as well as posted on the University of Pittsburgh Internet-Based Studies in Education and Research, the SIER website. For CME purposes, please be advised that both Dr. Kimball and myself have no disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the PA chapter of the American Academy of Pediatrics or its funders. Now, please allow me to introduce my friend and colleague, Dr. Eve Kimball. Dr. Kimball is someone who's been involved in our Pennsylvania Medical Home Initiative since the inception, and I've had the great privilege of knowing her for many years. And I think she is someone who has taught me a great deal about oral health and certainly inspired me myself to start fluoride varnish in my office. So I just wanted to say that at first. Eve, thank you so much for being here. I want to formally introduce you. Dr. Eve Kimball completed her rotating internship at Fitzsimmons Army Hospital and pediatric residencies at Madigan Army Hospital and Children's Hospital National Medical Center after receiving her undergraduate BA in zoology at Wellesley College and her medical degree at the University of Medical Center in Charlottesville, Virginia. She founded 2 private practices of her own, including her current practice, All About Children Pediatric Partners, located in Reading. She is our chapter champion of oral health, and she's an oral health advocate at our PA chapter of the AAP since 2008. And she's the medical director for Healthy Teeth, Healthy Children in Pennsylvania, which is a medical dental collaborative based at the chapter office. She's been involved in the Medical Home Project, as I mentioned, and the Chronic Care Initiative since 1991. And her practice achieved a level 2 in 2002 and a level 3 in 2016 in the NCQA Medical Home certification. Her advocacy has been well recognized with numerous awards, including the 2009 PA chapter of the American Academy of Pediatrics Outstanding Pediatrician of the Year Award and the 2016 American Academy of Pediatrics Oral Health Section Advocacy Award, in which she is most proud. She wrote Your Child and You, The Metamorphosis of a Family for her patients in 1980 and has co-authored several other scientific papers, including a recent publication using dental navigators in the medical office. Since 1971, she has held assistant and associate clinical professorships at George Washington, Georgetown Catholic, and Hershey Universities, and currently is a clinical instructor at the Rochester Institute of Technology. We're delighted to have Dr. Eve Kimball here to present with us today on this timely and important topic for primary care clinicians. Thank you so much, Eve. We're really excited.
Hi, thanks so much for allowing me to present my favorite topic. And I advanced the slides because they're slow. These are all the people without whom I could not possibly present this session for you. That's the learning objectives Renee already talked about, so we'll skip over them. Positive outcomes of including oral health in your pediatric practice is what I really want to emphasize today, because it's super, super important that we all think about the mouth and look at the mouth not just as a mouth, but a mouth with teeth. Primary teeth are important. I know all of you have heard somebody say, oh, they're just baby teeth, they're not going to matter, they'll go away. Prevention works. We know that 85% of all dental caries are preventable. And that's huge for in our pediatric world of prevention. This is something that we can really focus on. There's some indication that preterm births and other illnesses may be decreased or improved with good oral health. There's certainly evidence for diabetes, that it improves control of diabetes to have a caries-free mouth. That will increase your revenue, and it's cost-effective health care to do it. Why us? why are we being picked on again for something else? We see kids 10 times at least by the age of 2. And we can screen for that decay, along with when we talk about obesity and we talk about nutrition to prevent anemia. And this slide just shows the connection with obesity and the high calories and the frequent, in the case of teeth, it's the frequency of taking in sugar drinks, particularly from sippy cups. That's the problem in the epidemic that we have of early childhood caries. And we all know the risk of anemia with excess milk and juice drinking as well. Oral health impacts overall health in a huge way. We need to remember that that caries can be fatal, and we don't ever think about that. But we did lose 12-year-old Diamante Driver because of unattended to caries, and it wasn't his mother's fault. It was that he couldn't get to dental care. I had a toddler at the age of 2 who's now 8, who has an immune deficiency disorder, who's now alive because we recognized that he had caries as the cause of his brain abscess. And then there was most recently a truck driver at the age of 24 who was driving across country and didn't get care and died. So 50% of 5 to 9-year-olds have caries, 78% of 17-year-olds have had caries, and 85% of all adults have had at least one or maybe more, mostly more dental caries, all of which are preventable. And of course, it's 5 times as common as asthma, and it is the most common chronic infectious disorder of childhood. We're all about children with special health care needs in the Medical Home Network, and they are the super most important place that we need to focus on the teeth, because we have effects from medications with decreased salivary flow, with gingival mucosa overgrowth from phenytoin, with oral candida when kids are on steroids for their asthma, and dental caries from the frequent meds, the oral suspensions and sedatives. In addition, there are behavioral influences for the special needs children, improper and limited home care, because you know it's really hard when you have a child with special needs that there's lots of things to do and the teeth get neglected. In addition to which, there's a whole lot of aids that can be used for children with cerebral palsy, for example, to be able to brush their teeth. Positive reinforcement with food and beverages is very common, unfortunately, and all of that is cariogenic because it's frequent sugar, and we'll talk about that in a minute. And then a revision of their overall hygiene schedule may have to be done, and then that impacts their schedule. The other thing is that with a medical immobilization, they don't move around, and it's very hard to get them to a dental provider who can accommodate folks in wheelchairs and folks with limited mobility. And then the G-tubes and the muscle paralysis that causes decreasing clearing of the debris and pouching and decreased bolus movement. I have a lot of slides. I'm going to go through them fast, as you can tell. I mainly wanted to get this information out so you can review it again. The children with special health care needs, we need to conduct a risk assessment. They must have a dental home by the age of 1 or when their first tooth comes. This is like malpractice if we don't get them to the dentist. And they need to see the dentist every 3 months. If that's done, you don't end up with those terrible mouths full of plaque and looking awful. If any dental oral health pathology is seen, they need an immediate consult the next day. And also need to emphasize the prevention strategies with parents, and you will have fluoride varnish in your office. You can apply it at all checkups, and you can also apply it at ill and follow-up visits. In Pennsylvania, you will be paid. Thanks to Drs. Westerberg and Kelly. And finally, you have to do this because it's a B recommendation from the U.S. Preventive Services Task Force. That means that we have to do it, and that means that it also is paid for by the insurance. Parents don't have to pay for it. Both on private and public insurances. And all of the private insurances, the commercial insurances, along with all of the managed care organizations for Medicaid, cover fluoride varnish in Pennsylvania. The one of the commercial insurances that doesn't cover fluoride varnish, unfortunately, is TRICARE, and we're working on that as we speak. I've just gotten 2 more contacts of folks at the National Academy who are going to work on it. You'll notice here pictures of early childhood caries on the left, progressing to brown lesions, and then progressing to tooth loss and abscesses. We want to catch them when those white things that are right at the gum margin that you see that the arrow's pointing to, because those can be reversed by us in the office by application of fluoride varnish, and then we can get them to the dentist to continue their care. So dental caries is a complex disease. It's a multifactorial disease. Saliva in the mouth is the buffer. It's the basic substance, as in basic pH, that buffers the acid that's produced by microorganisms that we know are all in the mouth. And the minute the microorganisms get fed with carbohydrates, they love to produce acid, and that's what etches the teeth. And if that acid is produced, if the sugar is introduced frequently, and the saliva doesn't have time to buffer the acid that's produced by the microorganisms, we end up with decay. So it's teeth, time, carbohydrates, microorganisms, resulting in decay. And this is just my favorite slide, or one of my favorite slides, because it shows what happens through it when people have sippy cups, when children have sippy cups that they're sipping on all day, and it has just that teaspoon of apple juice that's in the water. And if you ask folks, what are they drinking? Oh, they drink water in their sippy cups. Well, the second question that you need to ask is, are they adding anything to the water? And you'll almost always get that, oh yes, because he doesn't like plain water, so we're giving him a little bit of apple juice in there. So you see, there's only one time at 7 a.m. and at 12 p.m. on this whole continuum where the pH is in the safe zone. That means it's buffered by the saliva. And this I just want you to have and look at later, but the protective factors that favor mineralization of teeth and thus prevent caries is the salivary flow, fluoride, vitamin D, calcium phosphate. Fluoridated water is so important. I need you guys to be advocates, please. And then the biofilm and the healthy gingiva. So we just talked about, and you see here the white spots are next to the gum. There are sometimes when there's white spots on the bite surface of the teeth, and those are frequently not early childhood caries. They are other just things that happen, sort of like white spots on our nails. But when you see those white spots up next to the gum, that's when you need to paint them with fluoride varnish in the office. And be sure that your children are brushing twice a day with fluoride toothpaste, and that's even under 2 they need to brush with fluoride toothpaste. By the way, Bucks, Montgomery counties both, neither one have fluoridated water. Reading has fluoridated water in or Berks County has fluoridated water in Reading and in Boyertown. But across the state, we're only at 54% of water fluoridation. So you really need to look up under My Water's Fluoride and look and see if there's fluoride in your local water supply. But if you're encouraging the kids to brush their teeth twice a day, and we'll talk about swallowing the toothpaste or spitting and then not rinsing and not washing it out, that will at least provide some fluoride for them. So across the lifespan, why is oral health important across the lifespan? Dental care is the most common unmet health need that we have. And this was back in 2000, and it's still true. We're getting a little better, but the disparities that exist in oral health access for especially the older folks and the younger folks and the middle folks, because they don't have enough money, is difficult. So 47% of adults age 30 or older have periodontal disease, and 70% of adults that are 65 or older have periodontal disease. And there's 70,000 oral cancers diagnosed annually, with 14,000 of them dying. So this is a big deal. For children, poor performance in school because of the pain, the aesthetics and the self-image issues. Adults don't go to work because they don't feel good. They don't chew, so our nutrition goes down. I had a teenager who was 16 who had diabetes. Couldn't get her diabetes under control. Looked at her teeth, and she was in foster care. She had a total of 8 totally rotten teeth in her molars. She had been seen by the dentist who had filled her bicuspids and told her to come back in 6 months and have the others worked on. She was telling the the people who were in the group home, in charge of the group home, that she needed ibuprofen because her mouth hurt, and she was telling them that she could only eat soup because it hurt to chew. They thought she was malingering. We got her teeth extracted. She began to be able to eat well, and her diabetes came back under control. Speech and language problems occur, obviously, if you're missing your teeth. And then there's costly ER visits and even more costly restorations. Adolescents, the oral piercing is a problem, and I love this picture because it's just, we're starting to see some of things like that. And HPV vaccine, obviously, we're all into getting HPV to our teenagers so that they can be protected. The relationship between periodontal disease and preterm birth is still trying to be, we still don't have good quantitative data, let's put it that way, but it looks like the inflammatory response to oral health disease is what's impacting a lot of other disorders. Need to remind your obstetrician friends that dental treatment is safe during pregnancy, through the whole of pregnancy, and it's really important because our mothers have medical assistance for pregnancy, many of them, and they otherwise don't have insurance. So it's important to get their teeth fixed while they have insurance that at least covers the fixing of their teeth. And how about young adults? The young adults have the highest number of ER visits of anybody because they don't go to their preventive dental visits because they don't have money, and it's a low priority on what they want to spend their money on. And then there's seniors, and we just talked about seniors. They have root caries, they have the gingival recession, and it's just more than 50% of people over 65 have no teeth at all. They have dentures. Early lesions can be arrested with fluoride toothpaste and varnish. And that's a message. You're going to hear it from me a lot. Larger lesions are going to require restoration, and we're going to talk about silver diamine fluoride in a little bit. So 30% of seniors have untreated caries. 25% have lost the supporting structures. We talked about periodontal disease. And this says more than 25, it's actually closer to 50% over the age of 65 don't have any teeth. They have troubles eating, and their faces don't look right. And even though dentures are helpful, they're not as good as the original teeth, but they can improve the quality of life with improving speech and appearance and making eating easier. In Pennsylvania, we're very fortunate to have adult dental coverage that's basic. Adults can go twice a year to the dentist. They can have one set of dentures, which is not ideal, but at least they can get one. They can have fillings that they have to get a benefit limit exception for other things, but they cannot have implants. Root canals can be done under a benefit limit exception. A lot of seniors have xerostomia, have dry mouth because of their medicines, and they don't drink a lot of water. The other thing is the disconnect. A lot of people have medical homes now, or more than used to, especially children. But more children are likely to lack dental insurance than medical coverage, and very few dentists accept medical assistance. It's important to look in your neighborhood and find out which dentists do accept medical assistance. And in the list of resources, there's the resource that you can go online and see who accepts Medicaid, and then call them, the ones that are in your area, and see if they actually will take new patients. Some of them will accept Medicaid. They won't accept new patients. Some of them accept Medicaid. They won't see children at the age of 1, which is what we are recommending. 95% of physicians think that, or 90%, think that oral health should be addressed at well visits. But 50% of us have no training in oral health. And only 9% could answer, 9 out of 100 could answer 4 simple oral health questions correctly. Clinicians averaged 2 or less hours of oral health training in their entire life. That's really tough. Give me just a minute, I got a cough. There. The relationship with oral health and systemic health is the inflammatory mediators. They seem to be the things that cause the problems. The potential links between Helicobacter pylori infection, adverse pregnancy outcomes, coronary artery disease, obesity, and metabolic syndrome. This link is still being worked on and is not. There was just an article that was published that said that we should be a little careful about making this link. As we talked about here, there's strong evidence. It's not strong quantitative evidence. It's strong qualitative evidence. There is good evidence, though, for caries prevention and getting diabetics in glycemic control. So we say all children should see a dental provider by age 1 or the first eruption of the first tooth and continue to have dental visits. We recommend fluoride toothpaste. A rice-size smear under age 3, pea-size throughout childhood, and it's okay to swallow that because it's 0.25 milligrams. You'll recognize that dosage. That's the beginning dosage, and 0.5 is the dosage for the older kids, and 1 milligram is the dosage for the adult and adult-sized children. So an acceptable substitute for fluoridated water, if we can't get fluoridated water, is to have the children brush their teeth twice a day. They're more likely to do that than they are to take supplements. Only 10% of children take the supplements that we offer to them in terms of vitamins. The other way that I like to think about how big a smear of toothpaste to put on my toothbrush is the size of my little fifth digit, my pinky fingernail. That comes out to the same size as a rice-size smear under 3 and a pea-size smear through childhood. And then for adults, a little bit bigger smear, but not a noodle. So, and then doing oral health screening and fluoride varnish application at well visits. And please, 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 water in between meals, not juice. So healthy food for a healthy mouth, real important. Just a little bit about mouth guards and concussions. Another place in your athletes to please talk to them about using mouth guards to protect their teeth, the adolescents, and keeping them, the mouth guards may actually reduce the impact of concussions as well. Prevalence of oral cancer, we talked about, and HPV-positive cancers are more frequent in white men and in younger populations, and in people who don't use tobacco or alcohol. The overall 5-year for oral cancer survival rate is only 50%, so not nice disease to get. The infective endocarditis that occurs from spread of the bacteria, the oral flora, through the cavities and into the bloodstream, and that's how my little guy got his brain abscess. We all know about joint replacements, and there's all kinds of controversies about that, but for the first, at least the first year, they do recommend dental prophylaxis after joint replacements, and then after the first year, not at all. Management of anticoagulation, again, having fillings on folks, those patients that we have that are anticoagulated is touchy, and that's where you need to coordinate with the dentist that's seeing them so that those get managed correctly. So fluoride. Fluoride's a naturally occurring element. It's in great quantities naturally in the Rift Valley of Africa, in India, and in China. And that's where the antis get all of their information from. And just like milk and water and a lot of things that we use every day, fluoride in excess amount is toxic. But fluoride in the appropriate amount strengthens the teeth by helping to convert the hydroxyapatite to fluoroapatite, which is much harder. Fluoride toothpaste and rinses, professionally applied gels are all topical fluoride, and the sealants and the varnish are both fluoride compounds. Systemic fluoride is from swallowing water or fluoridated water, toothpaste that we swallow, and it strengthens the enamel during tooth development. Excess can produce fluorosis. This is what fluorosis looks like. I would submit to you that it's better to have this than no teeth at all or rotten teeth, even if, and mild to moderate at the worst is the type of fluorosis that we see. And interestingly enough, nowadays, where we're seeing fluorosis is when children have been given fluoride supplement by compulsive parents who make sure that they get it, but then they also go and drink fluoridated water and use fluoridated toothpaste, which they swallow, which we want them to do. So the toothpaste amount twice a day is a really good way to get the fluoride into all of us. And we talk about children under 8 are the ones that are at risk for fluorosis. After the age of 8, the fluoride is not deposited in the teeth in the large amounts. That said, it's really important all through the lifespan, and especially for seniors, to keep their teeth in good shape. So in Canada, the varnish has been used for a long time. This is what it looks like. This varnish that's in this little packet is yellow-orange. It's no longer yellow-orange. It's now white. I want you to notice that the brush is bent. Really important because it makes it a whole lot easier to get the varnish onto the teeth, and we'll be happy to come and teach you how to do that if you would like. Varnish can be applied under Medicaid by physicians, nurse practitioners, PAs, and RNs. Commercial insurance, it has to be done by the clinicians themselves. Begins after the eruption of the first tooth, and every 3 to 6 months, up to 4 times a year, up to the age of 5 for medical assistance, and up to the age of 6 for private insurance. Important to know that you can put it on in your office, and the dentist can put it on the next day in their office. The child will not be hurt, and the dentist will also get paid. This is just the tools that are needed to apply fluoride varnish, and you just paint it on the teeth after lifting the lip. Silver diamine fluoride I want to mention because it's a new compound. It's actually not a new compound, but it's coming and is produced in a very reasonable, it costs about 10 cents a dose. It's a safe and effective treatment for dental caries across the age spectrum, and it's indicated for patients with extreme caries risk who can't tolerate conventional care or are medically compromised or frail. That's our young children who have decay in their primary teeth because the enamel is so thin, and for our seniors who are in nursing homes and skilled nursing and can't get out. And they can, when they develop caries in their teeth, those can be treated with silver diamine fluoride without having to be drilled and filled. This can also help with our disparity in access to care. This picture just shows the application of silver diamine fluoride to a cavity. The cavity is on the left, and the silver diamine is on the right. And you will see black. It's just like applying silver nitrate to cauterize belly buttons. Same principle. It just has the silver nitrate kills the bacteria, and the fluoride stimulates the tooth to change its hydroxyapatite to fluoroapatite and makes a really hard covering over that cavity. Can be repeated every 2 weeks until the cavity is clear. So what's best for your office? Barriers to accessing care are the lack of awareness, competing demands for time, financial barriers, dental providers uncomfortable with crying infants and toddlers, and they're not trained. In dental school, most of the dental clinics don't even accept children under the age of 3. So general dentists had no experience with 1-year-olds and with how to manage them. We're trying to work on that. We have some program called Connect the Dots in Pennsylvania that we're working on training the general dentists how to deal with the young children so they can provide the anticipatory guidance to those families before the caries begin. Providers not taking Medicaid, opening up the blinders and changing our practice paradigms is probably a biggie, probably the biggest. And we don't go to the dentist. I won't ask you to put your hands up in your offices, but think about how many of you have seen the dentist within the last 6 months. Probably less than 50% of you, because most doctors don't go to the dentist until they hurt. And then the social determinants of health that are barriers as well. So primary care physicians can refer. We can do risk assessment, we can examine the teeth, we can apply fluoride varnish, we can educate parents and children, and we can refer to the dental home. And we should do that every time people come into our office. This is a revised caries risk assessment that Margarita Fontana put together at the NCE in last November that I think is a really good one, and I wanted to put it in there for you. And you really don't have to go through each one of those things. If you read them, they're all things that just by walking in the room and maybe asking if the mother has gotten or the parent has seen the dentist recently, or has the child seen the dentist recently. The rest of it you're going to see in the course of your exam and in the course of your history taking. There's really no extra work on our part to do that risk assessment because we're already doing it. The reason for us to do a risk assessment is to, on the way to the tonsils, examine the teeth and the soft tissues. If we see white spots or dark spots or ulcers or bleeding gums, heavy plaque, unusual lumps and bumps, the ulcers may be herp angina, so we may not need to refer those to the dentist. And if the teeth are okay, we don't need to do that. But we still need to tell the folks that it's really good to brush your teeth and your tongue. Don't forget to have people brush the tongue. And then this is to tell you how quickly, you need to refer the child to the dentist. If they have any of these things, they need to get to the dentist. If they have bleeding or heavy plaque, if they have unusual lumps or bumps, or if they have frank caries, they need to get to the dentist in the next week or two. This is just the tooth eruption chart so that you have it. And this is what healthy teeth looks like, to remind you. Gingivitis is the red around the gums. Periodontitis is when that redness has progressed and the gums retract from the root of the tooth. And this is the one that you and I can prevent from happening. Whenever we get that phone call, and we all get it, from the parent who says, my child just fell and they banged their front tooth and it's loose, or it's fallen out. If it's fallen out, they need to put it in a glass of milk and take it to the dentist right there. If it hasn't fallen out, they need to watch, and we need to tell them, even if they've gone to the dentist, tell them to watch the gum above that tooth. And if it starts looking at all red, and parents can know the difference between redness on one side and not on the other, they should either see their dentist immediately or see us so we can get them to the dentist. And that can prevent these periapical abscesses that then have to have root canals done or tooth extractions. This is just a bunch of congenital defects. You've all seen Epstein's pearls and natal teeth. The enamel defect, you have to differentiate from fluorosis. Or from caries. You can see that the enamel defect is not up next to the gums. It's down at the bottom of the teeth. And then the tight frenum and frenulum that some of us are learning to release in the neonates so that they can breastfeed. Just some more oral pathology. So patient education and referring to the dental home. Our key messages. Healthy teeth are important. They matter. Brush teeth and tongue, both, twice a day with fluoride toothpaste. Just a smear is okay. And floss between the teeth once they get tight every day. First dental visit by first birthday, early in pregnancy, and at least once a year. Limit juice and sugar to once a day with a meal. Fluoridated water is best. Please be advocates for fluoridated water in your communities and pay attention to when the anti-fluoride people have gotten the water authority people to say that fluoridating the water is too expensive and so they have to take it out. That's been their modus operandi lately, and we've had some good successes in preventing that, but we need all of you to be really alert, and if you find out that your local water supply is not fluoridated, contact us and let us know, and we'll get you the resources that you need to get to those water authority people and get the fluoride back in the water. And drinking only water between meals. Not sharing food or utensils with infants to prevent transmission of bacteria. And then after vomiting, oops, there's a typo, rinse the mouth with a solution of 1 cup of water and a half a teaspoon of baking soda. And then be sure that dental sealants are applied to protect the permanent teeth. Please only plain water in sippy cups between meals. And how to do dental referrals. Your best source for finding a dentist to refer your patients is your own practice employees' dentist and your own dentist. When they go to the dentist, ask them if they will see patients at a year of age and if they'll take medical assistance and if they'll see an emergency when you call, and then get to know your dentist locally. You'll find it a very rewarding experience because they will call you about things that they're seeing in the mouth that they need to understand or that they're concerned about, and then you'll be able to call them and ask about things that you can see in the mouth. I've been very fortunate because almost 50 years ago, well, it is 50 years ago now, I had the opportunity to receive free dental care from my pediatric dentist on the condition that I would look at teeth on the way into the mouth. And he would be available to me by phone, and I had his office and his home phone, and answer any questions that I had and see folks immediately if I needed him to do that. I ended up with the same relationship with 3 other pediatric dentists in the Washington, D.C. area, and got really good continuing education from them. And we developed a wonderful relationship. I've had the opportunity to do that everywhere that I've practiced medicine, and I encourage you to do this because it really enriches your care of your patients. This is talking about making it work for you. This is your normal kind of office flow. The things in the blue are what will normally happen in your office. The things in the green are your assistant can give the patient, your medical assistant can give the patient information about oral health and put the varnish and those materials in the room. And then you would be in the room, do the screening, do the varnish. There's an alternative. If you collaborate and work together with your dental providers and your staff, you can have a dental assistant to give patient information about oral health. The assistant can put the varnish on, do the risk assessment. Then you can see the patient, apply the varnish, or the dental assistant can provide the varnish, and then someone can do the educational materials and a warm handoff to a dentist. Patients will keep their dental appointments at the rate of 90% if you make the dental appointment before they leave the office. If you don't, it will be 40% if you hand them a list of dentists that you know will accept their insurance, and 10% if you just hand them a list that you haven't vetted. So vet the list. This is a third way that suggestions of ways that you can have oral health in your office. Community health workers can now receive oral health training so they can do both the work of the community health worker and a dental navigator. Dental hygienists who have nothing other than their dental hygiene degree can do risk assessment and referral in your office under your supervision in Pennsylvania. We're very lucky that way. Or you can get a public health dental hygienist. They have had 1,500 or 1,800 hours of work with a dentist And they can either work under the supervision of a dentist doing the whole of dental hygiene in your office, or you can hire them to do the things that are in green in your office, and you can supervise them. You can't do prophies in your office without dentist supervision right now. But these are all alternatives that are available in addition to having a dentist or a dental hygienist in your office. I would caution you that one concern about having dental hygienists in your office is that sometimes patients think that that means that they've seen a dentist and then they don't go to the dentist. So important to get them both the hygienist education, the prophies, and then off to the dentist to be sure that they're following them for x-rays and for other stuff. This is your codes that you want to use. There's 3 CPT codes that you can use. A reminder about the take-home messages, and that oral disease is prevalent throughout the life cycle. So not to forget that it's in addition to kids. That oral and systemic health are interrelated. Most oral disease can be prevented through appropriate diet and good hygiene. Primary care providers, that's us, can have a major impact on the oral health of individuals and communities through team-based collaborative practice between medical and dental providers. So please don't forget to lift the lip and look at those teeth. I hope you've learned that there are positive outcomes from oral health in the pediatric medical office, that early childhood caries is preventable, that sippy cups and frequent sugar beverages link early childhood caries to obesity. So we're already doing that education, and it follows through for oral health prevention. That oral health has a huge impact on health across the lifespan. That fluoridation of our water supplies is the most important public health measure of the 20th century. And that silver diamine fluoride may be a useful, non-invasive treatment for caries in primary teeth. And then that you can use community health workers, dental navigators, hygienists, and PhDHPs in your office in a cost-effective manner. And this is my final slide. These are your resources. Healthy Teeth, Healthy Children.org is from the Academy of Pennsylvania chapter. Smiles for Life Oral Health, 8 modules that you can get free CME and have some additional education. AP.org Oral Health has many resources for in your office. The shopaap.org Equip Oral Health has maintenance of certification for implementing oral health in your office, and they are, I think, in the process of revising that, but it's good through 2020, I believe, 2019 or 2020. Maternal Child Health .org has some wonderful resources, and My Water's Fluoride is the fluoride concentration in tap water anywhere in the U.S. Real easy to find. Takes you to the CDC website. Insure Kids Now is how you're going to find your dentists who accept Medicaid. AAPD is pediatric dentists, and the ADA, of course, has some really good things. Once a year during Children's Dental Health Month in February, they have free posters that you can download. So that's enough from me. These are our links. Kristen is very, very helpful and will get any answers to questions for you that if she can't answer them, she'll get hold of one of us. And now, do you all have any questions? And I'll turn it back over to my colleagues.
Thank you, Dr. Kimball. That was great. Iris, do you want to go over the Q&A instructions?
Absolutely. So for anyone that's on the phone, if you want to hit #6 to unmute your lines, you can do so. And for the folks that are on the computer, you are more than welcome to type in the Q&A box. Again, that's #6 to unmute your line. And anyone that has any questions or any comments, you can type them in the Q&A.
And Iris, you're going to have to ask me the questions because I can't see the Q&A box. I did something. I don't know what I did.
That's fine. No worries.
Eve, this is Renee. I have a question. Do you know anything about, well, I actually have two questions. One is the silver diamine, is that that's something that insurance is paying for? I'm not sure if I have the right name. I just remember one of the dental residents here at St. Chris was telling me about, it might have been silver diamine, but that insurance wasn't covering it.
Yeah, so Medicaid is in the process of covering it. The private dental insurances cover it. Truly, it is so cheap that it's a shame if people are not using it, because it really does cost just about 10 cents. It's the silver diamine comes in a multi-dose container, and it takes less than a half of a drop to treat the tooth. It's not something I think that we're going to be able to use at least for a while, but I think down the road it may be something that physicians can have in our offices to treat those kids that have such terrible mouths and that we can't get them to the dentist for a month. You know, to use out in rural areas where it's really hard to get kids to the dentist.
Absolutely.
So what I would say is stay tuned on the silver diamine fluoride. I think it's important that we know what it looks like because we're going to see those black teeth. And then we'll see how, there's a research study going on in New York City, and it'll take 6 years to know. It may end up being something that we use instead of fluoride varnish. So if we can, for 6 years, put fluoride varnish on and learn how to do it, then we can learn to do the silver diamine after that.
That sounds great.
If it pans out.
We have, thank you, Dr. Kimball. We have just a comment from one of our participants just saying thank you for a wonderful presentation and thank you for being a great resource of consultation for all pediatricians, in particular in Pennsylvania, about oral health. So I just wanted to share that with you.
Well, thank you. It's a lot of fun, and I'm going to retire January 1 from my practice, but I don't intend to retire from the oral health world because it's too much fun.
We have another, I know, well, we're going to miss you, but you'll always be our oral health champion, I'm sure. We have another question, Dr. Kimball. Our office had tried making a dental appointment for the patients in the past and found that there was a high no-show rate for these appointments that were made. We do give the patients a list of dental providers. Do you have any other suggestions for our office to help facilitate follow-up?
Yes, and that percentage of people that keep appointments will go way up if you will have either you or your office personnel make that appointment before they leave your office. It just emphasizes to the patients how important dental work is. Remember that everybody's afraid to go to the dentist. We think that we have troubles getting people in. The dentists have a whole lot more trouble getting people in. And it's so important, yes, to develop that list, but to have, what we do in the office is we have a list of providers, and our medical assistants ask if the patients have a dentist and if they're happy with the dentist, because we have a bunch of folks who are dentists that we would not recommend. And so if they're going to those dentists and they're unhappy, we give them the name of another dentist. And we pick up the phone and dial the number and hand the phone to the patient so that while they're waiting for us, they can be making that appointment. What we have in our office is we have a dental hygienist. She's a public health dental hygienist who happened to be my hygienist, and her dentist retired, and she was trying to look to see what she wanted to do, and I said, and she loves teaching and she loves children, And I said, Mary Grace, such a job as I have for you. And she has worked out extraordinarily well. She loves kids. She loves to educate. She comes a total of 20 hours a week in our office. And she goes and talks to the patient, to the families while they're waiting for us. It's been a win-win situation because the patients are thrilled that they have somebody to talk to, that they got an extra free benefit and that we didn't charge them for it.
But do you believe, that's a quick question though for the hygienists, because
Yeah.
I thought that Dave Kelly said at our QI boot camp that the public health dental hygienists weren't able to be billed for in Pennsylvania yet.
They are not. But when she came, it increased our providers applying fluoride varnish by 34%. I mean, our income doubled. We went from $50,000 to $90,000 a year from fluoride varnish income. And it costs us literally $20,000 for her a year. It's $25 an hour. So
I see.
we could have her, and we may have her eventually put the varnish on. But if she puts the varnish on, it just takes longer, and I'd rather have her get more families educated. If that makes any sense.
I totally got you. I just wanted to clarify the billing.
No, thank you. Yeah.
There was some confusion about that.
Yeah,
But you feel like, and can you clarify for the audience the difference between a public health dentist hygienist and a regular hygienist?
Regular hygienist, yeah. So the PHDHPs, public health dental hygiene practitioners, have a little bit of coursework extra. They are people who have a 2-year associate degree. They then work in a dentist office for, I believe it's 1,800 hours. Please don't hold me to that. I think that's what it is. It's a number of, it's more than 1,000 hours in the dentist office. And then they have to take a couple of extra courses. Not many. It's not a master's, and it's not a bachelor's degree level. And then they can work in federally qualified health centers with a dentist supervising them, but they can actually, many of the FQHCs now have dental hygienists in the pediatric side of the FQHC, and they do prophies, and then they make the appointment with the dentist. The dentist must see them once a year after that. That's the public health dental hygienist. The dental hygienist is someone with a 2-year
we have
associate degree who is then ready to practice in a dental office doing prophies. And those folks, the dental practice regulation says that it's the paragraph number 4 says that those hygienists can work in anywhere doing risk assessment and doing referral to the dentist. I don't know who put it in there, but we're one of the few states that has it in, and it's wonderful. The other thing I want to clarify is the CPT codes that are on that slide with the CPT codes. The 99188 is the fluoride varnish application, and that's all that it is for the private insurance. For Medicaid, that includes the risk assessment and the referral. The other 2 codes are for the risk assessment counseling, and those you'll need to negotiate with your private insurers, but negotiate hard because there's no reason they can't pay for those. And then that helps support your hygienist in your office.
That's great. Thank you so much, Dr. Kimball. I think we're just about at 1 o'clock here on the hour, and I just want to be cognizant of time. And I want to just remind folks that anyone who's interested in receiving the free on-site fluoride varnish certification training by Healthy Teeth, Healthy Children at your office, you can email HTHC, that's Harry Churchy, Harry Cat, at PAAAP.org, and I know Eve had those emails in her slide. And I just want to thank Dr. Kimball again for her excellent presentation, and many thanks to the Pennsylvania Department of Health for the funding that made this webinar possible. This concludes our webinar, and wishing everyone a happy and safe, healthy summer.
And brush teeth and tongue. Thank you.